Conventionally, intracranial pressure raise is equated with papilledema. But there can be a trap in this. A drowsy patient with a head injury has no papilledema. Most of us do relax his ICP when it must be normal. But the real trap is that you can have life-threatening intracranial hypertension and even impending herniation with a completely normal fundus. Papilledema is late. ICP dynamic. Intracranial pressure is dynamic and deterioration is sudden. Intracranial pressure follows the ventricular artery. Brain plus blood plus CSF is a fixed intracranial volume. Early compensation occurs while CSF displacement and venous outflow when there is raised volume in the brain. Once exhausted, even a small volume increase can produce an exponential increase in ICP, thus reducing cerebral perfusion pressure, resulting ischemia, edema, and the vicious cycle goes on. Herniation syndromes are often driven not just by absolute ICP, but by pressure gradients across the compartments. So yes, ICP may be normal globally, but dangerously high locally. If you look at the BEST TRIP trial, it published in NEJM in 2012, ICP-guided therapy versus clinical imaging-based care showed no mortality difference, emphasizing the numbers of ICP don't always save the patient. It is the physiology that does. Now let's see what about the ICP value and the ICP trace forms. So more than the ICP value, ICP wave trace forms are good. Normal waveforms have 3 peaks. P1 is the percussion or arterial pulsation, P2 is the tidal which shows the brain compliance, and P3 is the dichrotic. When P2 wave is more than P1, it indicates reduced intracranial compliance, often predicting a raised ICP, overt raised ICP. So a raising P2 is an early indicator and warning sign than the absolute ICP elevation. You can intervene even before the numbers cross 20. Now coming to the hyperventilation myth. Hyperventilation lowers ICP via cerebral vasoconstriction. So it decreases cerebral blood flow. Effect is transient and lasts only 6 to 24 hours. It reduces cerebral perfusion, risking ischemic injury to the brain. So use only for temporary measure in impending herniation, not a routine continuous management. So focus on CPP and clinical trajectory. Maintain CPP more than 60 mm, cerebral perfusion pressure more than 60 mm, and not just ICP less than 20 mm. Both are actually needed. If a patient deteriorates neurologically, act on the clinical signs immediately. Don't wait for ICP monitors or papilledema. Give hyperosmolar treatment with mannitol or hypertonic saline. Elevate the head. Optimize ventilation. Time is brainstem in this case. It's not the ICP number that kills the patient. It is the loss of compliance and perfusion in the brain. Both do harm for the patient. Thank you.